Howdy ladies, good to see you today. We're going to talk for a few minutes about seizures and headaches. Very different categories, but things you're going to see frequently. First, let's talk about seizures. Don't get freaked out. Seizures are scary, but controllable. Let's just talk about the three categories that you'll deal with for the most part. We're not going to deal with the medicines right now. We dealt with some of that last time. But let's just calm for a minute. Patient with seizures. Three big categories. First, the febrile seizure. The child is between 6 months, 5 years of age. They're at most risk. It's when there's either a rapid increase or a rapid decrease. Please do not have your parents put children into a tub of cold water to bring down the temperature. It increases the risk of a febrile seizure because they drop that temperature so rapidly. Tylenol, Motrin, ibuprofen, that works just fine. There are family histories of febrile seizures in SIBS, and so you have to warn parents their next child may be at risk. Remember, febrile seizures, uncomplicated febrile seizures, do not put the child at risk for future epilepsy. That's very rare. Now, a complex febrile seizure, that's one that starts focally and then spreads or lasts more than 15 minutes, or there's more than one in 24 hours. It's recurrent. Different story. They have an increased risk of epilepsy. But for the most part, the febrile seizure patient will be between the ages of 6 months, 5 years. They'll have some sort of otitis media, viral infection. They'll have a tonic clonic. Remember, you have the tone and then the clonic, a generalized tonic-clonic seizure that will last a few minutes. The patient may be postictal, sleepy, kind of confused, hard to rouse, crying, agitated, and then they'll be fine after that. They do not need anti-seizure meds. Your job is to look for the seizure focus. Is it otitis? Is it a pharyngitis? Is it a urinary tract infection, gastroenteritis? Look for the cause of the fever and treat that. Teach the parents how to use the antipyretics, Tylenol every 4 hours, ibuprofen every 6 hours, or mix and match. Do Tylenol every 4, ibuprofen every 6, and alternate. There's little tricks that you can do to help the patients not seize again by keeping the fever down. But these patients are not at risk for ongoing epilepsy in uncomplicated febrile seizures. The other type that you'll see, and the most common one, is the partial seizure. The partial seizure come in two flavors. The simple partial, for instance, I had a patient who was a 30-year-old, and she would do this. Hello. And, someone bothered her. Why was she doing this? Did she have Parkinson's? No. Was she using some psychedelic drugs? No. She just had this simple partial seizure. No change in her level of consciousness. She was quite aware. She was quite awake. She would just do this. A little Tegretol, and it went away. The simple partial seizure. No change in their alertness. No change in their level of consciousness. Now, the other class of the partial seizure is the complex partial. They do have a change in their level of consciousness, meaning they won't be aware of what's happening. They're either passed out, they're gorked, they're not aware of their environment, their attention is shot, and often they will generalize. They'll start focally, and they can go to a generalized tonic-clonic seizure. Okay? There's a number of treatments, from typically things like Lamictal. You'll see more used these days. Tegretol, some, not quite as much as it used to be. A lamotrigine. There's other medicines out there, but the key is recognizing what's going on so you can classify that seizure. We typically don't use Dilantin for those. Dilantin is better for the tonic-clonic seizure. And that's the other category. The generalized or tonic-clonic seizure is one of the biggest categories, and we've talked about that already. And the absence seizure is also a generalized seizure. This is the child in the classroom just stares off. There's a change in their level of consciousness. They don't have tonic or clonic motions. They just stare off. absence. Okay? That can be treated reasonably well. Depakote can be used. And so the key is recognizing the pattern. A generalized seizure, tonic, clonic, or absence. The partial seizure, simple or complex when there's a change in level of consciousness, or the febrile seizure. Okay? Simple, down and dirty seizure disorders, so you don't get all bent out of shape about the different types of seizures. Now let's talk for just a minute about headache. The oldache, O-L-D-A-C-H-E. When you have a headache patient, if you'll just go through a systematic way of asking questions, you'll be able to determine, is it migraine, is it tension, is it mixed, or more rarely, cluster headache, tumor. Thankfully, those are more rare. You're going to see lots of you'll see lots of tension headaches, and you'll see some migraine. The other things will trail behind. O is for the onset. Does it come on all of a sudden? Or is it slow in coming on, like a tension headache? Migraine tends to come on fairly rapidly. What's the onset? The time of day. Does it always happen in the evening after a stressful day? Does it wake the patient at night? That's a red flag. Headaches that wake patients up, you better be thinking about brain tumor, something bad. Location. One-sided, unilateral, think migraine. Bilateral, around the eyes or in the back of the neck, think tension. Now, migraines can start on one side and generalize, that's true. But the classic migraine is a unilateral headache. Now, another unilateral headache is the cluster headache. Cluster tends to do that. It clusters in time, and then they'll be free of headaches for long periods of time. The cluster is extraordinarily painful. There's usually lacrimation, running eye, rhinitis, stuffy nose. Duration. How long does it last? The tension headache lasts for days. Oh, misery. The migraine tends to come on suddenly and come in paroxysms. It's there for a few hours, then it's gone. Okay? So the duration is important. What are the associated symptoms? The migraineur has nausea, vomiting, sounds bother their ears, lights bother their eyes. The tension headache patient typically does not have nausea or vomiting, does not have sonophobia, sounds bother them, or photophobia, light bothers them. That's very unusual in tension headache. What things are, what's the character of the headache? How do they describe it? The tension headache is described as a band or a vice gripping their head, versus the migraine patient is described, migraine headache, as throbbing or pulsatile. The cluster headache, lancinating, sharp, stabbing pains like someone sticking a knife in their eye. What helps it? This is the H of oldache. Rest in a quiet room with no activity, think migraine. Relaxation, a hot tub, a warm shower, think tension. What makes it worse? What exacerbates it? What triggers it? With migraines, it may be the menstrual cycle, alcohol, maybe a change in the weather. Activity tends to exacerbate migraines. So migraineurs like to be in the quiet room. Versus tension headache, stresses of the day, other intercurrent illnesses perhaps, family issues. Those are the sorts of things that trigger tension headaches. So here's a little table to compare the two, just summarizing what we've talked about. The tension headaches, gradual onset. The migraine may have an aura. They may smell smells or see things, scintillations, spots floating in their eyes. The migraine. Location. Again, tensions, bilateral, retroorbital, migraine unilateral. Duration, the days of tension, the hours of migraine. Associated symptoms, very few with tension, the nausea, vomiting, photophobia, and sonophobia of migraine. The character of the tension headache, the tight band versus the pulsatile throbbing of the migraine. Things that help the tension, fluids, nonsteroidals. the migraineur resting in that dark, quiet room, and finally the stress, worsening tension versus activity level, worsening migraine. Okay, we've talked a little bit about seizures. We've talked a little bit about headache. These are common neurologic problems that you're going to have to deal with. Okay, God bless. Remember, this is the day that the Lord has made. Rejoice and be glad. See you next time.